The inspiration behind the work, I think, came from a lot of different angles. Dr. Fumito Ito is a surgeon at USC who's really has a strong interest in chemokine receptors and how CD8 T cells work, and really was the driving force behind sort of developing the project. And then we had Robert Su, who does a great deal of database research here at USC, looking at large numbers of lung cancer patients, and really tries to understand the clinical factors that impact the response to different therapeutics. So we've done some work previously on things like neutrophil to lymphocyte ratio, and found that that was a very strong prognostic indicator for patients receiving immune checkpoint inhibitor. And so we really wanted to do something where we put together something that clinically made sense. And of course, what we found was that patients who, when they first are started on immune checkpoint inhibitors, which, as you know now, are the mainstay of treatment for a large number of patients with non-small cell lung cancer. If those patients were receiving corticosteroids prior to the institution of the immune checkpoint inhibitors, they didn't do as well. And they didn't do as well from the standpoint of overall survival. They didn't do as well from the standpoint of progression-free survival. And we also found that there was a little bit less in the way of response to therapy. And this really makes a lot of sense. The way that immune checkpoint inhibitors work is by making it so that the tumor is better recognized by immune cells. And of course, if at the start of therapy, if you're giving people a treatment that kills immune cells, if you're giving people treatments that reduce the number of them, if you give people treatments that make those immune cells less functional overall, you're not going to see the benefit of the immune checkpoint inhibitors. The treatment with immune checkpoint inhibitors is such that the target of the medicine is not the tumor itself. The target of the medicine is the immune system. It's really meant to get the immune system to work better. And so if patients are receiving something that makes the immune system work less, it's not going to be as effective. The inspiration for some of the work was from work that had been done by Fumito Ito in his lab, where he does work on T cell differentiation, the CX3CR1 score, which he uses in his research. And he was able to do a large numbers of work in animals that really corroborated the finding. And I think this type of approach of, bedside to bench research is something that I think is critically important that we do moving forward. When we do retrospective research on data sets of patients, we're effectively finding associations. We're not finding definitive causation, because whenever you're doing something retrospectively, you just know if two events are linked. The part where you develop causality really requires additional work. And so sometimes you can assume causality because of an obvious mechanistic factor. But I think in this case, we thought it was important to understand, what are the elements of the immune suppression caused by dexamethasone that really leads to the diminished efficacy. And so I think there's a lot of value of taking clinical associations and bringing them actually back to the bench to try to understand the why and the how. And that's an approach that I'd like to see used more often. People um, talk a lot about the issue of reproducibility in medical research. They talk about sometimes so many things are published with so many causalities and associations that people don't really understand what's important and what's not. And our job as medical scientists is really to understand nature, it's to understand biology, it's to understand fundamental principles behind what we're doing. And so being able to go back to the laboratory to try to get at teasing out the fundamental principles that underlie clinical observations, I think is really invaluable. And so really my hat's off to Dr. Ito for going back and um, doing the benchtop work that he did once the clinical association was readily apparent. We found that the presence of steroids um, in patients with lung cancer, the progression-free survival of the population overall that we looked at was about 10.7 months. If they weren't on steroids, if they were on steroids, it was only 3.2 months. And the overall survival of the patient population when there was no steroids involved at diagnosis was 21 months. And when steroids were involved, it was 7.7 months. When you looked, and that was for the Roswell Park Cancer Center. When we looked at the USC population, the numbers were almost exactly the same. Progression-free survival of 6.6 versus 3 months, and an overall survival of 16.4 versus 3.7 months. So one of the important things to do when you're doing retrospective research is to make sure that it's not just an accident of the particular database that you're looking at. So here we looked at databases from two different cancer centers and found that the direction of the association and the magnitude of the association was very similar. And I think that's something that I think has to be considered whenever you look at retrospective research, because people always worry that, well, maybe you were just data mining. Maybe this is something that was a sort of an accidental finding in your patient population. And so one of the things that we did here that I think was very important is make sure that the association was consistent in separate databases across different institutions. So that's what I think really is striking about the work in this case is that we know by being similar across two different institutions that it wasn't an accident. And then with the work that was done on the T cell work and the chemokine receptor work, we really did see markedly reduced percentages of CX3, CR1, CD8 positive T cells in the steroid treated population. And that really implicates that specific group as being one of the important drivers of the treatment effect that we observed. And then the mouse work that we did, I think also confirmed that particular finding. So what that suggests that there can be a lot of future directions that we can move into. Um, one of the things that is important is sometimes when we give these checkpoint inhibitors to patients, we need to shut the immune system down because we've actually had too much of an immune response. And patients sometimes need to get steroids because the checkpoint inhibitors have caused an autoimmune condition to occur. And that can sometimes be colitis, it can sometimes be hepatitis. And we can treat these folks with steroids, but maybe we only need to treat them with something that affects the CX3CR1 subset of T cells. And that might make for a cleaner drug. It might make for a drug, for example, that doesn't have all the other toxicities that steroids have. Giving people steroids causes a lot of hyperglycemia, for example, and can be a real problem in diabetics. And so one could imagine that, well, maybe we can just target this one particular cell fraction and get the benefit in terms of downregulation of immune activity with these agents without all the other baggage that comes with steroid therapy. That's one obvious thing people may look to in the future. But I think there's also something else that we can think of scientifically is saying like, well, maybe what we want to do, not in people who have autoimmune toxicity, but in people who have an inadequate response to immune checkpoint inhibitors, can we upregulate CX3CR1 T cells? And how might we do that? Is there a way to target that particular population, with medications? There's a lot of work now that people are interested in where we give people tumor-infiltrating lymphocytes, where we harvest lymphocytes out of tumors and then expand them ex vivo and give them back. And so when you think about a therapy like that, knowing which fraction of the T cells are important to give back may be very interesting. Are there ways that we can preferentially expand a subset of the population to give us the effects that we want? I think these are all important questions that the research that was done in this manuscript may help foster.